Good morning, everybody. I feel like saying Merry Christmas, but not quite, I guess. This is, coming close to Easter. Our third winter is here, so hopefully the last one. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So I'm going to hand it over to our Division Director for Pulmonary Medicine, Dr. Giovanni Ferrara, who had the foresight to invite our speaker today to give grand rounds. So over to Giovanni.
Thank you, Armin, and good morning, everybody. It's a sincere pleasure to introduce Dr. Atul Malhotra from the University of California, San Diego. Dr. Malhotra graduated here at the U of A, actually grew up in Edmonton, and graduated in 1992, then had his specialty training at the Mayo Clinic at Harvard. Worked there for 17 years before to move to the University of California, San Diego, where today he is the Vice Dean for Medical Research, as you see. Peter Farrell's Chair and Tenured Professor of Respiratory Medicine. He had an amazing career. He is the world leader about sleep medicine today. He has published more than 800 papers during his career. Has been the president of the American Thoracic Society, as you see in 2015-16. The ATS is the most prestigious scientific society in respiratory medicine. And not last, he had he received last year, in 2024, the Alumni Award from U of A for the excellence of his career. So it's a sincere pleasure to have you with us, Atul. Thank you so much for accepting our invitation, and the floor is yours.
Great, thanks so much for having me here today. I was born in University of Alberta Hospital and went to med school there, so it feels like I'm coming home and without the snow, so that works great. I'm going to talk today about pharmacotherapy for sleep apnea in 2025. There are some relevant disclosures down here. Eli Lilly paid for the study that I'm going to talk about regarding tirzepatide. ResMed gave a philanthropic donation to UCSD, but I don't take money from ResMed or its affiliates. So we've estimated about 1 billion people worldwide with obstructive sleep apnea. If you define sleep apnea as an apnea-hypopnea index greater than 5 events per hour, so one breathing problem every 12 minutes or so during sleep, it's about 1 billion people is what we published in Lancet Respiratory Medicine. This is a global initiative, including some Canadians up here, that estimated that number. There were only data from about 17 of the 197 countries. So part of our goal was to encourage further research. And since 2019, there have been some new studies that come out from West Africa and other places. The other point to make is that these numbers are increasing, not decreasing over time because of the obesity pandemic. MedX Cloud is an academic industry partnership. Again, I don't take money from ResMed or its affiliates. So you might say, who cares? There are 1 billion people out there with sleep apnea, but why do we care? If they're not coming to clinical fruition, just leave them alone. So Raphael Heinzer worked with us, and he published this with our group in Lancet Respiratory Medicine in 2015. And what they did in Switzerland is they went into the homes of people and did polysomnography sleep studies on people in Switzerland. I'll point out there's a lot less obesity in Switzerland than there is in the United States, although they're catching up. And in that context, he estimated about 23% of women, about 50% of men, had an apnea-hypopnea index over 15 events per hour. So 15 events per hour is moderate to severe sleep apnea. There's really no debate that these patients need treatment. 23% of women, 50% of men met that criterion in Switzerland. Again, you might say, who cares? If they're not coming to clinical fruition, leave them alone. Well, in that context, Raphael did a multivariate analysis, and the apnea-hypopnea index was predictive of hypertension, diabetes mellitus, and depression. So it's hard to say just ignore these people because we don't care about them. Obviously, they're afflicted with important conditions here, and you can't just ignore these patients. I'm not saying sleep apnea is necessarily causing any of these things, but it's hard to ignore these patients when they have important afflictions. There's a concept that emerges, too, that sleep apnea is highly prevalent, but not all these patients are likely to get cardiovascular benefit from CPAP, continuous positive airway pressure. Why do I say that? It would surprise me if 50% of men in Switzerland had benefit from continuous positive airway pressure, because not all of them are at cardiovascular risk from sleep apnea. Some will have death from cancer, some will die from Alzheimer's disease, some will die of heart disease for other reasons. And so it's not surprising that this one-size-fits-all approach has failed. So the take-home message so far, sleep apnea affects up to 1 billion people worldwide. The numbers vary with the scoring criteria and the equipment used. But we need to think about how to tackle this global burden of disease. This is a study that many people are familiar with from the New England Journal of Medicine from 2016, the so-called SAVE study. What they did here is they looked at CPAP, continuous positive airway pressure, for the prevention of cardiovascular events in people with sleep apnea. Therapy with CPAP plus usual care, as compared to the usual care alone, did not prevent cardiovascular events in patients with moderate to severe sleep apnea. So this was a bit disappointing for people that maybe treating sleep apnea wasn't helping. But as I point out, this used the sort of one-size-fits-all approach that just giving everybody treatment was going to help, and that approach may be doomed to failure. So at least for me, there were at least 4 take-home messages from the study. The first was we need better therapies and better adherence. They achieved about 3 or 4 hours of CPAP use in this study, which is their goal, but maybe that's not good enough. We need to identify high-risk patients better. Just giving CPAP to 50% of men in Switzerland is not going to work. We need more basic research regarding underlying mechanisms, which is a shameless plug for my lab. And then we need to treat the underlying cause. And so obesity is often the underlying cause, which was largely ignored in many of these studies. And so a bit like if you're treating COPD and you ignore smoking, you're probably not a very good doctor. And so similarly, we were not addressing the underlying obesity very well. So there are different therapeutic approaches to obstructive sleep apnea. I point out CPAP, continuous positive airway pressure, holds the airway open. There are other ways of doing that with oral appliances and upper airway surgery, as we'll talk about. You can treat the underlying cause based on mechanism. The mechanisms here include weight loss, would reduce the obesity. You can promote tone in the upper airway muscles. There's a concept called loop gain, which we can talk about, which is related to control of breathing. You could use treatments to facilitate PAP adherence. So there's hypnotics and nasal patency could allow people to use positive airway pressure better. You can treat the symptoms, put a Band-Aid on the problem, perhaps with various medications we'll talk about. You can try and block the sleep apnea complications. I'll just talk a little bit about that as well. So this is a study we published in Chest a few years ago now, looking at patient engagement using new technology to improve adherence to positive airway pressure. There are people out there that say, oh, nobody tolerates CPAP, so don't bother even trying. And that's simply not true. So on the y-axis here is the percent of patients, and the x-axis here is time. On the cloud, there's over 15 billion nights of data on the cloud, and we can use those data for various different studies, as I'll show you. So this is drawn from almost 1 million patients, 137 million nights of data. The blue line here is usual care. And usual care had about 70% adherence based on US Medicare criteria. So not bad. If you look at other chronic medical therapies, be it inhaler use in asthma or anticonvulsant use in epilepsy, 70% adherence is actually quite good as far as CPAP is concerned with usual care. If you use active patient engagement, where patients get a thumbs up if they're doing well, they get helpful hints if they're doing poorly based on app, we're seeing up to 87% adherence based on US Medicare criteria. These two groups are propensity matched. It's not a randomized trial, but at least the data here is suggestive that the majority of patients will tolerate CPAP well. So the idea that nobody tolerates it is simply wrong. The other question I get is that, well, you have to have a CPAP machine to get onto the slide, and that's true. So if you simply refused CPAP or had no access to healthcare or couldn't afford a sleep study or didn't want the machine at all or had no electricity, you would never get onto the slide. But we tried to be as inclusive as possible. If you could get a machine and plug it in and use it for 1 hour in total, then we included you in this analysis. If you never got a machine, we'd never have a way to capture you on this particular study. So this doesn't pertain to all patients, but it does pertain to many patients. And in that context, the majority will tolerate CPAP quite well. And with modern technology, the vast majority are tolerating CPAP quite well. If that sample size was enough, we looked at 2.6 million patients here. Again, we're seeing about 75% adherence based on US Medicare criteria. What about global health? Well, we looked in Mexico and Brazil as well. So 4.1 million patients from the United States, 31,000 from Brazil, and 16,000 from Mexico. And in that context, we're seeing similar adherence based on Medicare criteria. 74% in the United States, 72% in Brazil, and 66% in Mexico. You might say, well, these are different patients, and that's true. Part of the point here was to compare across different health systems. So maybe the more affluent people in Mexico are the ones seeking care, and that's probably true. Maybe some people in Brazil are getting surgery because that's preferentially reimbursed based on their system there. But across the board here, we're seeing acceptable levels of adherence in these different countries. These patient engagement tools, active patient engagement, were associated with a 2 times benefit as far as CPAP adherence was concerned, and they're grossly underutilized. So these are built into the machines, and so you just have to turn it on, and many people did not. In that context, there's something actionable here where it could actually improve adherence even in under-resourced areas by just using the existing equipment. And it turned out about 80% of patients met Center for Medicare Services or US Medicare criteria at 1 year, suggesting potential sustained benefits. Now, there's various different analyses that have been done regarding adherence to CPAP therapy, and these studies are somewhat flawed. When people are adherent, have something called the healthy user effect. So healthy users tend to use their CPAP, they tend to follow diet and exercise instructions, they tend to be more affluent, they have better health literacy and all of that. So with those caveats, this is from 480,000 patients in France. We published this in Chest a couple years ago now, looking at survival probability on the y-axis. The patients who had continuation of therapy had better survival probability than those who did not. This is, as I said, a biased estimate in the sense that adherent patients do better than non-adherent patients, even with placebo. But at least the data are consistent that CPAP has some benefits here, and it's an association, not causation. Along those lines, there's a paper in JAMA that came out relatively recently out of Spain, where they looked at adherence to PAP therapy, and they did see improvement in cardiovascular events in that context. So adherence to CPAP therapy, continuous positive airway pressure, was associated with reduced major adverse cardiovascular events, suggesting that treatment adherence is a key factor in secondary cardiovascular prevention in patients with sleep apnea. Again, it's biased in the sense that the people who are adherent have better health literacy and better socioeconomic status than those who are not, but at least it gives us something to try to achieve in subsequent randomized trials. We had a meta-analysis that came out in the Lancet Respiratory Medicine a few days ago, and it showed something consistent in terms of all-cause mortality as well as cardiovascular mortality. So nasal CPAP here is first-line treatment for sleep apnea, improves symptoms, it improves blood pressure, has transformative benefits for some patients, and a defeatist attitude towards CPAP is not justifiable. People that say nobody tolerates it are simply wrong. But this general consensus that we need new therapies based on ongoing research, which will be the remainder of my talk. There are different forms of upper airway surgery that can be done. The hypoglossal nerve stimulator, you may see the ads on television, the Inspire device, was published in New England Journal back in 2014, 11 years ago now. And we're working on some other types of devices in that context. There's one called the Osprey study by a company called LivaNova, and full disclosure, it was the global PI for the study not yet published, which I'll show you a headline from in a second. But the THN3 study was published in JAMA ENT last year, and we did see in that context improvements in the apnea-hypopnea index, not complete elimination, but some improvements in the apnea-hypopnea index and in the oxygen desaturation index at 1 year, suggesting that this proximal hypoglossal nerve stimulation may be working. We did a subsequent study, and it's not published yet. The manuscript is in preparation, but we did release a press release. This company, LivaNova, again, I'm the global PI, so I have a disclosure there, announced the Osprey study results. The clinical study meets primary safety and efficacy endpoints. There are some potential advantages of this proximal nerve stimulation. It's an easier surgery, and it doesn't have all the requirements that the Inspire device has. The study design was published here in Contemporary Clinical Trials a year or two ago. So more to come on this. I can't say more about that other than I'm working on the manuscript as we speak. So we can treat the underlying cause based on mechanisms. So sleep apnea has a variety of different mechanisms. Not all sleep apnea patients are the same. We know that clinically, and we know that from research as well. So Li Xuan-Yi is a nurse who used to work with us in Boston. Prior to that, she was at the University of Pennsylvania and published this study with colleagues in Iceland. And she identified 3 different clusters within sleep apnea, phenotypic clusters. Some have disturbed sleep, like with insomnia, and that's about 1/3 of patients. Some are minimally symptomatic or asymptomatic, that's about 25% of patients. And some have severe excessive daytime sleepiness, about 43% of patients. The interesting thing there is the 43% in subsequent studies were found to be the subset who are at high cardiovascular risk. These other groups were not. So again, it's not surprising that randomized trials just taking one size fits all and giving half of the men in Switzerland CPAP is not going to work because only fewer than half of the patients are at cardiovascular risk from their sleep apnea. There are lots of mechanisms or endotypes underlying sleep apnea. There's anatomical factors. There's the upper airway muscles, which we think are important. There's the arousal threshold or propensity to wake up. This concept of loop gain, which is a ventilatory control factor, or something called lung volume or vascular effects. I work in the intensive care units as well. I do a lot in the mechanical ventilation area. This concept of loop gain is exactly the same in mechanically ventilated patients who have breathing instability. The bottom line take home for a general audience is patients don't all get sleep apnea for the same reason. The mechanisms vary. This one size fits all approach has largely failed, just trying to give everybody the same treatment. There is a treatment that's out there which is available in the States, and actually there's some Canadians involved in this technology as well. But what it is it's a daytime oral stimulator. You put this in your mouth for 20 minutes a day, and it exercises the muscles electrically and improves their endurance. And so the tongue muscle endurance here is improving with this treatment, and that's associated with improvements in the apnea-hypopnea index as well as snoring and the Epworth sleepiness score. And so it's a daytime stimulation. People put it in their mouth when they're driving to work, whatnot, 20 minutes a day during the daytime to improve the endurance of the muscles, and that is leading to some improvements in clinical parameters here. More definitive multi-center randomized trials are now in design. I should disclose here, I don't take money from this company either, but I do have a friendship with the CEO. Okay, so you could use treatments to improve symptoms in sleep apnea. So we know people with fragmented sleep get daytime sleepiness and fatigue and whatnot. What can you do about that? So there's a drug called solriamfetol or Sunosi, which we studied. We did a Delphi conference, which we also refer to as herding cats. We did a global consensus, including some Canadians here, where we looked at recommendations for clinical management of excessive daytime sleepiness in patients with sleep apnea, a Delphi consensus conference. And this was published a year or two ago now in Sleep Medicine. This global consensus can be challenging because it's like herding cats. Some basic technologies like actigraphy, these motion sensors, are not widely available in some countries. The multiple sleep latency test, which is how we quantify sleepiness, also was not universally available. So those were not in the global recommendations. But there was general acknowledgement that about 10 or 20% of well-managed sleep apnea patients who are using positive airway pressure treatment still have residual sleepiness. And that 10 or 20% may be amenable to pharmacotherapy. We made a big emphasis on primary therapy, be it CPAP or oral appliances for treatment of sleep apnea. But even then, about 10 or 20% will have residual sleepiness and may be amenable to pharmacotherapy, such as Sunosi, solriamfetol. So treatments to block complications. So we know sleep apnea leads to intermittent hypoxemia and hypercapnia and catecholamine surges. So could you just block the complications of sleep apnea? And just giving you this, I know it's a general audience, but just as a kind of teaser for where the future might lie. We know that there are gut bacteria in the microbiome that release various metabolites. There's one called TMAO, which is released by gut bacteria that we think is important in atherosclerosis. So in rodent models, we can give intermittent hypoxia with hypercapnia, and see what that does to atherosclerosis. There's a drug called DMB, which can block the choline metabolites like TMAO. So TMAO had a New England Journal paper about 10 years ago showing that it was being released by gut bacteria and that it was promoting atherosclerosis. If you look at lesion area here in the y-axis in the aorta, in the aortic arch, you can see intermittent hypoxia with hypercapnia to mimic sleep apnea is leading to increase in the lesion size. This DMB to block it leads to some minor reductions here, although not significant. If you look at the pulmonary artery, though, you're seeing some marked increase in atherosclerosis with intermittent hypoxia and hypercapnia, and some improvement in that with this DMB. And so suffice to say, it's sort of a new area for us where we're trying to block the complications of the hypoxia and hypercapnia, some of which may be mediated by gut bacteria. Okay, so let's talk about weight loss. So as you may know, there's some excitement about some new data that came out relatively recently. So I'll give you some insights into that, hopefully. We published this meta-analysis relatively recently, just before the SURMOUNT OSA result was released. On the y-axis here is the percent change in the apnea-hypopnea index. That's a marker of sleep apnea severity. On the x-axis here is the percent change in the body mass index or weight. You can see here as the body weight comes down, the apnea-hypopnea index improves on the red line here. The blue dots here are lifestyle studies. These are people that looked at diet or exercise, and you see some relatively minor improvements in body weight with some concomitant improvements in sleep apnea severity. The green dots are medications, and these medications were given to try to induce body weight loss, which they did, and that also led to some improvements in the apnea-hypopnea index on the y-axis. The black dots are surgical studies where you see more marked weight loss and more marked improvement in the apnea-hypopnea index. A couple things to emphasize here. Number one is that there's a fair amount of scatter here. So some people lose weight and their sleep apnea basically resolves. Other people still have a fair amount of residual disease. It's not all related to body weight. There's complex mechanisms underlying these individuals. Number two is there's a lot of debate about the shape of this curve. Some people think it's linear. Some people think it's curvilinear. Some people think it's quadratic. Suffice it to say, the more weight you lose, the better, as far as sleep apnea is concerned. Clinically, some patients seem to have a threshold where they get below a certain threshold and they're largely resolved. But suffice to say, this shape of this curve is debated. And the other point I'd like to make is that if you look at the SURMOUNT OSA result, which I'll show you in a second, we saw about 50% improvement in body weight, we saw about a 20% improvement in body mass index, and that led to about a 55% improvement in the apnea-hypopnea index. It falls on that red line, suggesting that the amount of body weight we experienced was sufficient to explain the improvement in the apnea-hypopnea index, suggesting that maybe off-target mechanisms are not needed to invoke the mechanism of improvement. That is to say, the mechanism of improvement in sleep apnea may be largely from weight loss. The SURMOUNT OSA result was published recently in the New England Journal of Medicine. The study design was in Contemporary Clinical Trials, published in 2024. This is tirzepatide for the treatment of obstructive sleep apnea rationale sample baseline characteristics. Tirzepatide is also known as Mounjaro or Zepbound. It's a GLP-1 receptor agonist with GIP. So GLP-1 is glucagon-like peptide 1, similar to Wegovy or semaglutide. With GIP. GIP is gastric inhibitory peptide, also known as glucose-dependent insulinotropic polypeptide. I'm married to an endocrinologist, so I know more about GLP-1 receptor agonists than I care to admit, although I have deep knowledge in that minor area, and otherwise I know enough to be dangerous. Suffice to say, this molecule is quite interesting and has led to a lot of excitement. So the study design for SURMOUNT OSA, again, recently published in New England, was the following. There are two different studies, Study 1 and Study 2. Study 1 were patients who were not on CPAP. They couldn't or wouldn't use CPAP therapy. And Study 2 patients were patients who were on CPAP. And in both situations, they're randomized to get either tirzepatide at the maximum tolerated dose or placebo. In Study 1, non-CPAP patients got tirzepatide or placebo. Study 2, tirzepatide patients got CPAP plus tirzepatide or placebo plus CPAP. So let me say that better. Patients on CPAP were randomized to get either tirzepatide or placebo in Study 2. Maximum tolerated dose was escalated over time. A couple things to emphasize. Number one is all patients in both studies got diet and exercise instructions, including monthly visits with registered dietitians to optimize diet and exercise. We withdrew the CPAP for 1 week prior to each sleep study to show that the drug was actually doing something rather than that the CPAP was working. And we were careful about inclusion-exclusion criteria. Some sleep apnea studies are predominantly male. Some weight loss studies are predominantly female. So we were careful to include a good gender balance in our study design. So inclusion criteria, it was adults over 18 years of age, moderate to severe sleep apnea based on apnea-hypopnea index over 15 events per hour. You had to have a BMI over 30. So there was nobody here with mild sleep apnea, nobody was lean, nobody was overweight based on these definitions. We excluded people with diabetes, type 1 and type 2 diabetes. That's important because the data suggest that there's less weight loss with GLP-1 receptor agonists in people with diabetes than people without diabetes. The other criteria were fairly standard. So the objective here is to demonstrate that tirzepatide at the maximum tolerated dose, once weekly by injection subcutaneously, is superior to placebo for the change in the apnea-hypopnea index from baseline to week 52. The key secondary outcomes, I'd like to emphasize something. All of them were controlled for multiple comparisons, and all of them were pre-specified. So there was no data dredging or fishing or any of that kind of nonsense. These are all pre-specified key secondary outcomes. So we looked at the percent change in the apnea-hypopnea index as a marker of sleep apnea severity. We looked at the percent of participants with more than 50% reduction in the apnea-hypopnea index, which is clinically and statistically significant. Percent of patients achieving what you might consider remission, AHI below 5, where there's no sleep apnea left, or between 5 and 14 without symptoms. Epworth Sleepiness Score below 10 is relatively asymptomatic. We looked at the change in the sleep apnea specific hypoxic burden, which is a marker of cardiovascular risk. We also looked at changes in systolic blood pressure, which is obviously important. We looked at the percent change in body weight, which obviously patients care about. We looked at the change in the high sensitivity C-reactive protein, which we know from the Jupiter study and others is a strong cardiovascular risk marker. And we wanted to make sure we weren't just making the numbers look better, but the patients were feeling better. And so we looked at patient-reported outcomes. The PROMIS scores are developed by the U.S. National Institutes of Health. And we looked at sleep-related impairment, which is daytime symptoms, and sleep disturbance score, which is nighttime symptoms. In isolation, these patient-reported outcomes are somewhat meaningless. You can't blind a study where somebody's losing 20% of their body weight because it's obvious who's in which group. But these patient-reported outcomes are important in the context of concomitant changes in objective outcomes. I'll show you two sets of results as we go. There's an efficacy analysis, which are patients that stayed on drug, and there's a modified intention to treat. And the two have almost identical results, but I'll show you both for transparency. So in study 1, these are the non-CPAP patients. They got tirzepatide or placebo. Study 2 were the CPAP patients who got tirzepatide or placebo. The vast majority of patients completed the study. There were some dropouts in the placebo arm, probably because of lack of efficacy. People don't want to give themselves injections every week if it's not doing anything. But for the tirzepatide group, most people stayed in the study, and the completion rates are actually quite good. If you look at drug discontinuations, there were more in the placebo, presumably because of lack of efficacy. But in the tirzepatide groups, very few drug discontinuations in study 1 or in study 2. If you look at adverse events, arguably they're more with placebo than with tirzepatide in study 2, numerically more with tirzepatide than placebo in study 1, although, again, the numbers are small. If you look at baseline demographics, these are typical patients we see in our clinics. So 48 years old or 50 years old is what we see typically. It's about 30% female by design because, again, many sleep apnea studies are predominantly male, so we want to avoid that. We had about 40% Hispanic, which was quite good, and so we had good diversity across the board here, which was great. You might say that Black or African Americans are fewer than you'd like. The study was done in 9 countries. There are very few African Americans in Europe or in Asia, so within the United States, we did quite well for Black or African American. Across the study, it's fewer than you might like, but it's because of the demographics globally rather than locally. If you look at the body mass index, there's class 2 obesity, so BMI of 39 in both study 1 and study 2. We excluded people with diabetes, but many of them had pre-diabetes and hypertension, as you can see there. And so relatively obese cohort here. They had severe sleep apnea. Their apnea-hypopnea index of 51 events per hour. 60 per hour would be a breathing problem once every minute. So 52 per hour severe sleep apnea in both study 1 and 50 per hour in study 2. We excluded mild sleep apnea, so most were, or all of them were either moderate or severe. And these are the symptom scores. The Epworth Sleepiness score goes up to 24, so 11 is actually relatively modest for a sleep apnea cohort. And the reason we think is that these patients were largely enrolled from endocrine and bariatric clinics rather than from sleep clinics, so they may be less symptomatic than what we're used to seeing. So the study was published in the New England Journal of Medicine, as I mentioned, in 2024. I'll just tell a personal story, which was funny. I told my daughter that I have a paper coming out in the New England Journal of Medicine, And she said, how many times have you been there, Daddy? And I said, I don't know, I'll check. So I looked it up and I said, well, it's 13, but some of them are reviews and editorials and they don't really count as much. And I said, but it's 13. She goes, 13, but Daddy, it comes out every week. So I guess we can't please everybody. So look at the primary outcome, the apnea-hypopnea index. On the y-axis here is the change in the apnea-hypopnea index, and the x-axis here is time. In study 1, the non-CPAP patients, there was a marked improvement in the apnea-hypopnea index. And in study 2, there's a marked improvement. 30 events per hour is both clinically and statistically significant. So we met our primary outcomes. In isolation, this is meaningless because it's just a number that's getting better. We don't really care. So these key secondary outcomes are important in that context. And as I emphasized, all of them were pre-specified, all were controlled for multiple comparisons. There's no data dredging here. If you look at the percent change in the apnea-hypopnea index, it's about a 55% improvement in both the efficacy analysis and the modified intention to treat. In study 2, these are the CPAP patients, about a 60% improvement in the apnea-hypopnea index, both the efficacy analysis and the modified intention to treat. If you look at percent of participants with more than 50% reduction in the apnea-hypopnea index, it's about 60 or 70% in both study 1 and study 2 in the modified intention to treat, about 60 or 70% improvement in the efficacy analysis as well. And this is something I tell my patients at this point. If you go on this medication, about 70% of the time, 60 or 70% of the time, you'll have at least a 50% reduction in the apnea-hypopnea index. If you look at those that you might consider cured, that is an apnea-hypopnea index below 5, which is normal, or between 5 and 14, mild sleep apnea without symptoms, an Epworth Sleepiness score less than 10. It's about 40 or 50% in the modified intention to treat, and about 40 or 50% in the efficacy analysis as well. Now, there's some debate here. If the apnea-hypopnea index is below 5, you might not say cured. You might say they're in remission, but they could regain the weight if they stop the medication. Or the fat could redistribute over time. Other things could change. And so I wouldn't use the word cured there, but you might say remission. For these milder patients, it's a bit more controversial. There's lots of reasons we treat mild sleep apnea. It might be for fatigue, not sleepiness. It might be for high blood pressure. It might be for other reasons. And so I don't consider these patients cured. It's an individualized treatment with mild sleep apnea. If you look at the shift in the apnea-hypopnea index severity, in study 1, these are the non-CPAP patients. You can see some dropouts in the placebo. Severe sleep apnea with tirzepatide becoming much less frequent at 1 year with tirzepatide in study 1. Moderate sleep apnea also much less frequent at 1 year with tirzepatide in study 1. Study 2, severe sleep apnea again becomes much less frequent at 1 year in study 2. Moderate sleep apnea also less frequent. It's not that we're not impacting moderate sleep apnea. Some of the severe sleep apnea becomes moderate, so some shifting of stages there, but suffice to say the sleep apnea is improving in both study 1 and study 2. Let's look at other key secondary outcomes pre-specified. The hypoxic burden, the area under the hypoxia curve, percent change in the hypoxic burden here. This is based on the magnitude and duration and frequency of desaturation. So it's the area under the hypoxia curve, which we know is a strong cardiovascular risk marker. You can see here in study 1, marked improvement in the hypoxic burden with tirzepatide therapy as compared to placebo. In study 2, you see a marked improvement with tirzepatide therapy as compared to placebo. I often get the question, why is the placebo improving so much? And as I emphasized, all these patients are getting diet and exercise and monthly visits with registered dietitians. And so I don't think this is placebo effect. It's just the impact of good implementation of standard of care. So key secondary outcomes, cardiovascular related. Let's look at body weight. So with tirzepatide, seeing about an 18% improvement in body weight in study 1, about a 20% improvement in study 2, both in the efficacy and in the modified intention to treat analysis. To put that in context, 200, or if I weighed 200 pounds at baseline, a 20% improvement would be from 200 pounds to 160 pounds. That's a 40-pound weight loss, which is quite a game changer. If you think in kilograms, 100 kilograms would be 20 kilogram weight loss, which would bring it to 80 kilograms. Quite a game changer for these patients that are losing that much weight. Let's look at high sensitivity C-reactive proteins, the modified intention to treat on the left, the efficacy analysis on the right. marked improvement in the high sensitivity C-reactive protein, both in study 1 and in study 2. This we know is a strong cardiovascular risk marker from the Jupiter study by Paul Ridker and others. If you look at systolic blood pressure, this is perhaps the result that surprised me the most, a 9.5 millimeter mercury improvement with tirzepatide in study 1, perhaps slightly less in study 2, but marked improvements in systolic blood pressure in both the modified intention to treat and in the efficacy analyses. The diastolic blood pressure was not pre-specified. It was not controlled for multiple comparisons. So I won't dwell on this result, but the pattern was similar. Let's look at patient-reported outcomes. So the PROMIS scores were developed by the U.S. National Institutes of Health when that existed. The sleep-related impairment is here, and that is a daytime symptom. Sleep disturbance score is nighttime symptoms. Marked improvements in a pooled analysis that was pre-specified with tirzepatide as compared to placebo, and marked improvement in nighttime symptoms with tirzepatide as compared to placebo. As I mentioned, patient-reported outcomes in a study you can't effectively blind or interpret with a grain of salt, but with concomitant improvements in all the objective outcomes I showed you, I think this gets more compelling. So I'll summarize the efficacy analysis by saying tirzepatide demonstrates superior and clinically meaningful improvement of sleep disorder breathing compared to placebo. Tirzepatide demonstrates superior improvement in sleep-related functioning and quality of sleep compared to placebo. Tirzepatide demonstrates superior improvement of cardiovascular risk factors. All type 1 controlled key secondary outcomes were met in both studies for both efficacy and modified intention to treat. So absolute and percent change in the apnea-hypopnea index and the hypoxic burden improved. The percent with more than 50% improvement in the apnea-hypopnea index. The PROMIS scores, patient-reported outcomes, got better. High sensitivity C-reactive protein, systolic blood pressure, and body weight, all of those met clinically and statistically significant improvements. So let's talk about safety. There were no deaths, which was good news. Serious adverse events were relatively few and pretty much balanced between tirzepatide and placebo, arguably slightly more with placebo than with tirzepatide in study 2. Across the board, treatment emergent adverse events were around 75 or 80%, which is typical of these kinds of studies. These drugs do have gastrointestinal side effects. And so about 25% of patients will get nausea, vomiting, diarrhea, or constipation in study 1 with tirzepatide. Similar pattern in study 2, nausea, vomiting, diarrhea, or constipation, and about 25% of patients in study 2. The good news is here, very few patients stopped the medication because of these side effects. I showed you that at the beginning. The dropouts from the medication adherence were very few. And the other good news is these attenuate over time. So by 1 year, we had very few, if any, adverse events reported. So it wasn't that patients stopped the drug, they just habituate to these side effects. Adverse events of special interest, we're worried about death, we saw 0. We're worried about pancreatic cancer, we saw 0. We're worried about medullary thyroid cancer, we saw 0. There were some cases of pancreatitis. There were 2 cases in the tirzepatide group, 0 in the placebo. And as you may know, I work in the intensive care units, and so I know a modest amount about pancreatitis. And so I put my critical care hat on to dive deeper into these pancreatitis cases. And both of them were quite mild. And in fact, I couldn't figure out why they were diagnosed. And I believe what happens here is what's called an ascertainment bias. People come in with nausea, vomiting, abdominal pain, and people check an amylase and lipase just to see what's going on. And so these patients may not have been diagnosed outside of a clinical trial, but they were in the context of that. So these 2 cases are not to be ignored, but out of almost 500 patients, 2 cases of mild pancreatitis is something I tell my patients, but it's not something I worry about. To summarize the safety and tolerability profile of tirzepatide in people with moderate to severe obstructive sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and incretin-based therapies in people with obesity. The most frequent adverse events were gastrointestinal and were generally mild to moderate. GI adverse events were more frequent earlier in the study and attenuate over time. There were 2 positively adjudicated cases of acute pancreatitis. Both were quite mild, both with tirzepatide treated patients, 0 with placebo. So some people say, well, this is the end of CPAP, and that's certainly not the message here. There was no direct comparison of tirzepatide with CPAP. It was in non-CPAP patients, tirzepatide was better than placebo. in CPAP patients, tirzepatide was better than placebo. But what I believe strongly is that you don't treat either sleep apnea or obesity, you treat both. And so these data are consistent with that notion. So we published this recently in the Lancet Respiratory Medicine, just saying CPAP is here to stay. Many patients were not included in SURMOUNT-OSA, and so we can't draw conclusions outside of the study. And then, as I say, the take-home message here for general audiences that treating both obstructive sleep apnea and obesity is optimal for metabolic outcomes rather than treating either one alone. So key takeaways from the study: tirzepatide, the maximum tolerated dose, demonstrated clinically meaningful improvements in sleep apnea-related sleep disordered breathing. Tirzepatide, the maximum tolerated dose, demonstrates superior improvements in patient-reported quality of sleep and sleep-related functioning. Treatment with tirzepatide maximum tolerated dose translated to clinically meaningful improvements in sleep apnea and obesity-related cardiovascular risk factors. The safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide in incretin-based therapies in people with obesity. So this is my last slide, just to summarize what I was saying. Therapeutic approach to sleep apnea. You can use positive airway pressure to hold the airway open. You treat the underlying cause, including obesity. You can facilitate PAP adherence. You can improve symptoms, or you can block the complications. I'd like to thank you all for your attention. It's been my pleasure to be here today. I'd be happy to take any questions at this time.
Thank you, Dr. Malhotra. That was a wonderful presentation, and congratulations on this highly impactful study. I'm just going to kick it off before, I don't know if there's anything online or not, but so I just had a couple of questions. First of all, you know, you had alluded to it earlier, but I wondered, in your study specifically, did you see a correlation in terms of you know, of weight loss and improvement either in the AHI or clinical outcomes? So that was the first question. And then the second one, you know, maybe this is a good opportunity to talk a little bit about personalized medicine and being able to use tools in the clinical realm to decide, okay, which patients are actually going to benefit from what treatment, in the sense that, you know, you talked about not all sleep apnea patients necessarily have increased risk of cardiovascular outcomes. Not all will necessarily benefit from sleep apnea. Clearly, there's benefit from weight loss and CPAP, or a combination of. And so maybe, you know, just commenting on your thoughts on that.
Sure. Thank you for both questions. I'm not allowed to release the results yet. We sent a paper yesterday to Nature Medicine with some mediation analyses. So in these studies, you know, the body weight improved, the apnea-hypopnea index improved. And so how much of the changes are mediated by improvement in sleep apnea versus improvement in obesity versus a direct effect of the drug is not clear. So we just sent that paper off for peer review yesterday. I'm not allowed to talk about the results. However, there are some data in the literature about the carotid body. So with hyperglycemia, there's some pathoexcitation that can be mediated via the carotid body, and you can block that with GLP-1 receptor agonists. So my bias as a physiologist is that some of the improvements, for example, in systolic blood pressure, may be mediated through some pathoexcitation effects of the medication rather than from improvement in body weight per se. But that's a speculation on my part. Regarding the personalized medicine thing, I think you're raising an important issue, and the short answer is I don't know. I will say that symptomatic patients seem to get more bang for their buck than asymptomatic patients. And that Li Xuan Yi, she's a PhD nurse who worked with us in Boston. She had the different clusters. There was asymptomatic sleep apnea. There was some that had insomnia. There were some that had excessive sleepiness that was 43%. That's the group of cardiovascular risk. And so there weren't as many of those in the tirzepatide study just because we were drawing from endocrine and bariatric clinics. And so you might argue there's bigger benefits in the more symptomatic patients. But clinically, if you see somebody that's got severe symptoms, they probably need treatment. If somebody's asymptomatic, you'd have to convince me that they're, you know, that they really need aggressive therapy. Although, you know, diet, exercise, the standard of care things are certainly reasonable in that context.
Thank you. And I know you declared yourself you're not necessarily an expert in SGLT2s and incretins, but can you comment on muscle loss in your study with the incretins?
Yeah, so I'm married to an endocrinologist, so she says I know enough to be dangerous. It is true that if you just do starvation, if I just stopped eating, I would lose fat, but I'd lose skeletal muscle as well. And the problem with that is the skeletal muscle is what drives your basal metabolic rate. And so if you lose a bunch of weight as muscle and fat, and you no longer have a basal metabolic rate to burn calories, then your ability to maintain weight loss is impaired by that loss of skeletal muscle. So all these companies that have the GLP-1s are working on different skeletal muscle agents to try and preserve that. But it does emphasize something that I emphasized along the way, and that is diet, exercise, strength training, and getting people in the gym, and these things are important to maintain skeletal muscle. When you look at we didn't measure skeletal muscle in this particular study. When you look at the literature, it's quite variable. How much of the weight loss with GLP-1 receptor agonists, how much is fat versus muscle? I've seen ranges of 20 to 60%. So my bias is it's probably more fat than muscle that people are losing, but it is an important point. Whether that affects upper body muscles or diaphragm or other skeletal muscles, we don't know exactly. So that is the subject of an NIH grant that I just submitted, actually. So.
Before I go to another question online, I'll just look around. Yeah, Giovanni, why don't you come to the mic so your question can be heard?
Well, thank you so much. That was a wonderful lecture. Listening to your work, I really thought, but there is probably a very close relation between sleep apnea, metabolic syndrome, and aging. And the direct complication of aging is, of course, death. But the scariest to me is cognitive decline. Do we have any, data showing that treating sleep apnea can prevent cognitive decline? And the other question that I would have is in respiratory medicine, one of the best indicators we have is the pack here for smoking, for the risk of developing chronic disease. Do we have something similar for sleep apnea, or the severity of the disease is still the best predictor of outcome and complications? Thanks.
Thank you. I have a question for you, Giovanni.
Yeah, he's still here.
Yep. What
I have a question for you. Is it Baggio or Altabelli?
Sorry?
Baggio or Altabelli?
Baggio
What
or Altabelli?
I'm a fanatic sports fan, as some of you know. So,
Oh, okay. Baz. Okay.
So the first question is about cognitive decline, and it's an important question. So I actually have an R01 grant for the NIH to study sleep apnea and Alzheimer's disease, Alzheimer's risk. The short answer is the following. It's a long answer, but I'll tell you a little bit. There was a paper in JAMA about 15 years ago by Yaffe, which was an observational cohort study where incident new onset Alzheimer's is increased in untreated sleep apnea compared to matched controls. Their data by Holtzman from WashU in St. Louis published in Science in like one of the top journals, where they looked at amyloid and tau accumulation in the brain with sleep disturbance in both rodents and in humans. You can see amyloid and tau increasing with sleep disturbance, suggesting that could be a problem. This ApoE epsilon 4, that gene that's associated with Alzheimer's, is also associated with sleep apnea, so there may be common predispositions there. It turns out that GLP-1 receptor agonists can block the hyperphosphorylation of tau, which we know is important in Alzheimer's risk. If you take a normal, healthy person and sleep deprive them, there's a paper in the Proceedings of the National Academy of Sciences where you can see increases in brain amyloid with sleep deprivation in normal people. Even within 24 hours, you can start to see increased amyloid, which is kind of scary. There's a lymphatic system in the brain. Some of the lymphatics in the lung. There's a glymphatic system in the brain that expands when you go to sleep. And the idea is that you're flushing out toxins and taking stuff out of the brain that may be accumulating, leading to neurocognitive decline. So we published in the American Journal of Respiratory Critical Care Medicine a few years ago a randomized study of CPAP versus usual care. And we saw improvements in memory using CPAP therapy in that context. There's a type of memory called memory consolidation. So if we have a conversation today, we may or may not remember it tomorrow. It turns out about 80% of the variance of what you remember we can predict by how well you sleep tonight. So it's referred to as sleep-dependent memory consolidation. And the idea there is the amount of sleep you get after learning something has a big impact on how much memory you'll consolidate. it's more important than your age or your gender, or your IQ, or where you went to college, or your race, or anything else, how smart you think you are. 80% of the variance you can predict by how well you sleep tonight. And CPAP will improve that sleep-dependent memory consolidation. Whether it actually prevents Alzheimer's or not is the subject of a grant I just submitted. Whether GLP-1 receptor agonists can block that hyperphosphorylation of tau and have an impact on cognition and things is the subject of a grant I just submitted. So the other question you asked was about, remind me, Giovanni?
It was about potential way to measure the width of duration of sleep apnea compared to severity, and that if that has any effect on the outcomes.
Yeah, so it's a big problem. Our metrics, our yardsticks for sleep apnea severity are not very good. The apnea hypopnea index is a frequency. There's no other disease defined by frequency that I'm aware of. So it's the apneas plus hypopneas per hour of sleep. It's a frequency. And so that sleep apnea specific hypoxic burden is an improvement. It's looking at the magnitude and duration of desaturations and their frequency. It's the area under the hypoxic curve, and that has been shown to be a strong cardiovascular risk marker. So Ali Azerbaijan in Boston, who actually trained with Magda Yunus in Winnipeg, has done some nice work in that area. But the short answer is we need something better. We need better metrics that can explain different factors. The reason I'm hesitating a little bit is the answer is it depends. So if you look at 4% desaturations, that's predictive of hypertension. If you look at 2% desaturations, that's predictive of insulin resistance. If you look at duration of saturation below 90, that's predictive of platelet aggregation. If you look at frequency of arousals from sleep, that's predictive of memory consolidation. Nothing is a very good predictor of motor vehicle accidents. And so the biology is complex. It's not surprising that one yardstick doesn't predict 88 different complications, because how could it? They're all biologically different systems. And so the definitions and the PACI or equivalent might depend on your question. If your question is about cognition, that might be a different answer than if your question's about diabetes or about heart attack or peripheral neuropathy or something unrelated. So it's complicated, but there's progress ongoing in that context.
Thanks. Great lesson for students in medical school. If there's anyone listening or residents, is get your sleep before the exam, or at least for consolidation. So Cheryl Lorada, you probably know, is a sleep medicine's practitioner here, asks, there's some evidence about the proportion of tongue fat being associated with the AHI, and reduction in tongue fat with intervention had a stronger association with reduction in the apnea-hypopnea index than abdominal circumference. Do you think there's a role for medications like tirzepatide in patients with a BMI of less than 30?
Yeah, thank you, Cheryl. I certainly know Cheryl pretty well. Short answer is I don't know. So Richard Schwab has done the work on tongue fat, and he's been a proponent of that abnormality. So there's fat that deposits in the tongue as you gain weight, and that may have an impact on the mechanics of the airway. We did get MRIs in SURMOUNT-OSA in a subset. In fact, Richard Schwab is a co-author on the New England Journal paper, because his job was to do the imaging part of it. He was not happy with the imaging, and so those results are not published, and they may not be published. He didn't think the quality of the imaging was enough to hang the hat on. So I think tongue fat is probably important. It's probably not the whole story. I think he's probably overplayed the importance of it, to be perfectly blunt about it. Is there a role for tirzepatide in people with BMI below 30 is kind of a different question. The answer is maybe. The Food and Drug Administration approved tirzepatide as a drug treatment for sleep apnea on December 20th, 2024. That was a milestone for me, because I started doing work in this area in 1998, and I vowed to come up with a new treatment for sleep apnea, and it took 26 years, but we eventually got there with the drug treatment. The FDA label did not specify a BMI. They say weight-related complications. So arguably a BMI of 27 or 28 with obstructive sleep apnea is still obesity. It's not based on the BMI threshold. It's based on the consequences. So there is FDA approval at those lower ranges. There were no data, though, whatsoever in SURMOUNT-OSA for BMIs below 30. So from clinical experience and talking to my wife, who treats a lot of type 2 diabetes, I believe there probably is a role in the overweight. In the lean people with BMIs below 25, then I need to be convinced that it's either effective or cost effective to intervene with a GLP-1 receptor agonist in that context.
Good point. Okay, interesting question about efficacy of CPAP versus hypoglossal nerve stimulation. Are you aware of any direct comparisons, and are the patients actually happy with the nerve stimulation the way it's depicted on the TV commercials?
Yeah, the TV commercials are a little bit irresponsible, I think. It makes it look like a remote control, and patients come in saying, oh, I want the remote control. There are no comparative effectiveness studies that I'm aware of that compared CPAP with hypoglossal nerve stimulation. One of the criteria for implanting the device is that they've failed CPAP. Either they can't or won't use CPAP. And so which one's better? The CPAP is better in the sense that it's first-line treatment. And until somebody does a comparative effectiveness study showing superior outcomes with a more expensive technique, I'd go with the cheaper approach. Are patients happy with it? I'd say that varies. The response rate in the New England Journal, January 2014 paper, I wrote the editorial in New England about that. The response rate was about 65, 70% in that study, and that was with BMIs below 32. It was fairly hand-picked patients, and the response rates were good, but not amazing. If people do tolerate it, it's been a game changer for some patients. Patients will do anything to get rid of their CPAP. In that context, some of them are quite happy with the treatment. Whether that impacts long-term cardiovascular risk and things we don't know, we don't have those sorts of data. In the Osprey study that I mentioned that has the global PI, and we've collected blood pressure and more extensive patient-reported outcomes and stuff. So more to come. If you're coming to the American Thoracic Society meeting in May in San Francisco, that's a shameless plug for my talk. So.
Thank you. There's a couple of questions in the chat about the SURMOUNT study specifically. One is about whether further subgroup analyses were done for a decrease in AHI stratified to severity of OSA or obesity, and gender differences and age. And then the second was around medication treatment for patients in whom CPAP was inefficient, for if there would be a role for medication treatment for patients who did not respond to CPAP.
Well, I'll take the second question first. In patients who didn't use CPAP, that was study one. So study one was in patients who couldn't or wouldn't use CPAP, tirzepatide was better than placebo. I still believe in treating the underlying disease, and so I recommend CPAP therapy. If patients can't or won't use CPAP, then tirzepatide is better than placebo. So that's study one. In terms of subgroup analyses and stuff, because Eli Lilly is now $1 trillion company or close to it, there's a lot of issues about releasing data before it's gone through regulatory processes and stuff. So I can't talk about any of those things. In fact, they told me the SEC, the Security Exchange Commission, would investigate me if I start releasing those things. So the short answer is I don't know, or I can't say.
Okay, thank you. That's what I thought.
Stay tuned.
Well, once again, congratulations on all your accomplishments as a former alumna of the University of Alberta, and hopefully next time we'll get you here in person and presenting at our grand rounds. And thank you again for a fantastic presentation.
Thanks for having me. It's nice to come home.
Okay, take care.